I think I should start. Both the panelists have joined. So, good evening, everyone. I am Dr. Rambir Gulelia. On the behalf of Academy of Pain Physiatrists, I welcome you all to the today's second journal club organized by Academy of Pain Physiatrists. Today, we are honored to have with us two distinguished panelists. Both the panelists is from the anesthesiology background and have vast experience in the field of pain medicine. Let me introduce you to our first panelist, Dr. Jeshnu Tople. He is FIPP from USA, EDPM from Belgium, and FIAPM and FIPM. Sir is the director of Mitigate Pain Clinic Nagpur. He has published many research articles in various reputed journals and author of many chapters in various pain medicine books. Sir is awarded by Young Pain Physician of the Year Award at ICRA Pain Conference 2024. His area of interest are neuropathic pain and musculoskeletal pain. Welcome, sir, and thank you for accepting the invitation on a short notice. Now, I will introduce our second panelist, Dr. Prableen Kaur Chatha. She is the co-founder and consultant pain specialist at Jaipur Institute of Pain and Sports Injuries, GIPSI, where all round pain management services are provided to the patients. Ma'am has published many research articles and authors of various chapters in the books. She received various awards by ISSPCon and PISACon. Welcome, ma'am, to today's journal club. Both the panelists have made significant contribution to the field of pain medicine. Their input will not only advance our understanding of today's topic, but also had a direct impact on improving patients' outcome. We are privileged to have both the panelists to share their insights and expertise with us today. Now, I also introduce today's speakers. First speaker is Dr. Ashish Yadav. He is senior resident at PMR Department, AIMS Nagpur. And second speaker is Dr. Shalu. She is senior resident, PMR Department, AIMS Mangalagiri. First, Dr. Ashish will present the journal club, followed by the discussion on this journal club, and then second journal club topic will be presented by Dr. Shalu, followed by discussion. Over to you, Dr. Ashish. Please start sharing your screen.
Thank you. So,
Please start.
so it's visible. Good evening, everyone. Myself, Dr. Ashish Yadav, senior resident, PMR in Nagpur. Today, I am going to present on this paper titled "Comparison of the Selective Nerve Root Pulse Radiofrequency versus Paramedian Interlaminar Epidural Steroid Injections for the Treatment of Painful Cervical Radiculopathy." It get published in the 2024 in journal Pain Physician. This is a randomized controlled trial study. About the journal, this is a Pain Physician journal, is the official publication of the American Society of Interventional Pain Physician, having impact factor 4.396. In the background of the study, the radicular pain in the lower cervical spine is a common condition that affects a patient's quality of life and function. Global age standardized prevalence and incidence rate of radicular neck pain in the general population is 3,551 per lakh population. Neck pain is caused by compression or inflammation of nerve roots that exit the spinal cord through the intervertebral foramen, and C7 is the most effective nerve root responsible for this kind of neck pain. The techniques aim to reduce pain transmissions from the affected nerve roots are mainly following this fluoroscopy guided cervical epidural steroid injections, and second is ultrasound guided selective nerve root pulse radiofrequency ablation. Regarding epidural steroid injection, it involved injecting a corticosteroid and local anesthetic into the epidural space, that is the space between the dura mater and the vertebrae. The epidural steroid injections aim to reduce inflammation and edema around nerve root. This fluoroscopy guided procedures can be performed via various approaches like midline or paramedian approach. This injection by a paramedian approach provides safe, easier, and more effective access to the epidural space. This diagram is very relevant to this study. This shows the various approaches like midline intralaminar, paramedian approach, and this transforaminal approach for the nerve of the cervical epidural steroid injection. It also represents the A is that the posterior epidural space and B is the anterior epidural space. The dotted circle indicate compression of the spinal nerve root by a herniated disc, mainly in the anterior epidural space area, denoted by the B. So why paramedian approach is more safe? In this article, they mentioned that paramedian approach is more safe than midline approach due to most nerve root compressions are located in the anterior epidural space. It also mentioned that midline ligament flavum defect was detected between C7T1 in 93% of the cases in a cadaveric study. So it increased the risk of spinal cord injury during an epidural injection via midline approach. Hence, paramedian approach may provide safer, easier, and more effective access to the anterior epidural space where the compression and inflammations are located. Now, this ultrasound guided selective nerve root pulse radio frequency ablation. So, an ultrasound guided pulse radio frequency is a technique in which a pulse radio frequency energy is delivered to the cervical nerve root under ultrasound guidance. It allows direct visualization of the nerve root and the surrounding structures, such as vascular structures, that cannot be observed with the fluoroscopy. It also provides real-time feedback on needle placement and pulse radio frequency delivery. In ultrasound guidance, how do we identify vertebral labels is mainly due to with the help of morphology of the tubercles of the transverse process. Like in the C7 vertebra, prominent posterior tubercle can be seen while rudimentary antitubercle is seen. In this diagram, as we can see, the prominent posterior tubercle and the rudimentary antitubercle. While for the C6 vertebra, anterior tubercle is more prominent, that is carotid tubercle, while C5 more uniform anterior and posterior tubercle can be seen. So based on these ultrasound sonoanatomy, we can identify the selective nerve root. The objective of this study has the primary aim to compare the efficacy of the two methods. So to compare the efficacy of the two methods for the cervical radicular pain management. And the secondary aim, it compare the duration of the two procedures, its complications and adverse effects. And the inclusion criteria of the study includes age group of 18 to 75 years, radiating pain to the neck and one arm for more than 12 weeks. The pain of neuropathic characters, which they use S-lens score more than 12. Evidence of the radiculopathy by electroneuromyography. Unresponsiveness to conservative management. Only protruding disc herniations at C5, C6, C6, C7, and C7T1 level, not extruded or migrated disc herniations they have taken. No surgical operations done for cervical disc herniations, and absence of motor deficit in the arms and hand. Among exclusion criteria, the shoulder or arm pathology detected by the orthopedic assessments, inflammatory or rheumatological diseases, grade 2 severe foraminal stenosis, in the presence of cervical myelopathy, presence of motor deficit due to radiculopathy, coagulopathy, use of antiplatelets or anticoagulants, implanted pacemakers, any comorbidities like diabetes, hypertension, renal hepatic insufficiency, psychiatric illness, and injection site or systemic illness. All these are the exclusion criteria for the study. The methods, it is the prospective randomized control trial done on patients with lower cervical radicular pain. Written informed consent was obtained from all patients for interventional procedures and participation in the study. A computerized randomization program was used to allocate the patients to the group. The study subjects, the patients with chronic cervical radicular pain visiting OPD of a single center pain clinic. Then the sample size calculation was 30 patients in each group. All these subjects are randomly divided into two groups. Group U for the ultrasound guided radio frequency procedures, and group F for fluoroscopy guided caudal epidural steroid injections. This is the methodology flow chart which depicts how the assessments allocations for the both group patients has been taken. So all the ultrasound guided and fluoroscopy guided procedures were performed by an interventional pain physician who had at least 5 years of the experience in the pain field. Patients were monitored and vascular access was established for all the procedure. The patients were not sedated and the interventions were performed under local anesthesia. Duration of the procedure is calculated as the time from intervention of the ultrasound probe or the first image taken with the fluoroscopy and ended with the needle removal. In this way, this duration of the procedure time is calculated. Now, the ultrasound guided selective nerve root pulse radio frequency procedure. For this, patients placed in the lateral decubitus positions with intervention site on the upper side. Area cleaned and wrapped. Using a 5 to 12 megahertz linear probe, C5, C6, and C7 vertebral labels were identified according to morphology of a transverse process. Also, hypoechoic nerve roots identified between the tubercles and transverse process. After that, 22 gauge spinal needle inserted in the plane as ultrasound probe and directed from posterior to anterior. For this, 1.5 ml of 1% lidocaine was injected for each affected nerve root after negative aspiration for the diagnostic block. In this picture, where the first position is the position of the patients, and the lateral decubitus is lateral decubitus. Second, they can see this anterior and posterior tubercle for C6 nerve root, and this picture depicts the posterior to anterior nerve root, that needle direction. Those patients who reported more than 50% reduction in radicular pain for at least 2 hours after this diagnostic block underwent ultrasound guided selective nerve root pulse radiofrequency next day using 5 mm active tip, 60 mm radiofrequency cannula, and radiofrequency generator. Once hypoechoic nerve root is approached, current of 0.4 to 0.5 volt at a frequency of 50 megahertz was applied for sensory stimulation, and paresthesia response was obtained in a corresponding dermatome. After sensory stimulations, they have applied this motor stimulation for relevant myotomy at 1 to 1.2 volt at a frequency of 2 hertz. After that, pulse radio frequency was applied to each nerve root at 42 degrees centigrade for 4 minutes after a contraction response was observed. No medications was administered after radiofrequency ablation. In group F, this fluoroscopy guided caudal epidural steroid injection, patient positioned in a prone with pillow under chest to open the interlaminar space. Posterior neck cleaned and draped under fluoroscopy guidance, interlaminar space C7 T1 to be entered was identified. The site of the injection 1.5 to 2 centimeter lateral to the midline, 1 ml or 1% lidocaine applied to the skin with 27 gauge this needle, and 20 gauge Tuhi needle was inserted. Needle was guided in anterior posterior fluoroscopic view. Needle depth checked in the lateral view. In this pictures we can see the once the needle tip approaches the spinolaminar line, this is the spinolaminar line, epidural space was entered using a loss of resistance injector. 1 ml of the contrast iohexol injected to visualize the spread in the epidural space. The spread in the epidural space can be seen. After that, posterior to the anterior space, spread of the contrast medium within the epidural space is noted. Dexamethasone 10 mg and 0.5% lidocaine, that 20 mg injected into the epidural space at a total volume of 4 ml. All patients monitored for at least 1 hour. The outcome measures of the study is demographic data, analgesic medications, pain duration, affective nerve roots were recorded before and after the procedure. Contrast medium spread to anterior and posterior epidural space in group F is noted. Adverse effects, procedure durations were recorded in both groups. A clinicians who had never seen the patients performed the post-treatment assessment. For the assessment tools, for the efficacy of the treatment assessment, they have used numeric rating scale NRS 11 and neck disability index NDI at pre-treatment and 3 and 6 months of post-injection. Also, they use self-lead assessment of neuropathic symptoms and signs PEN score, that is S-lens, at pre-treatment and 6 months. For medications, quantification scale version is also used for at pre-treatment and 6 months for seeing the effect of treatment on drug consumption. These are the results for the study, in which we can see this age, mean age group for the both groups, gender, BMI are comparable in both the groups. Affective nerve roots, their sites and duration of the pain is also comparable in both groups, and basic analgesic are also similar in the both the groups. In intervention related and post treatment clinical features, the duration of the procedure duration in the ultrasound, ultrasound guided is 12 minutes, and the fluoroscopy guided the 6 minutes mean duration for the procedure. It also seen the vascular adverse events. There like 2 patients got the vascular events in the group U, that is ultrasound guided, and 1 in the group F, that is fluoroscopy guided. The NRS 11 at the baseline and 3 months and 6 months are the comparable. The NRS 11 NDI score, S-lens score was similar between the groups at the baseline. The NRS 11 NDI scores showed a significant decrease at 3 and 6 months post-treatment in both groups compared with the baseline, but there was no significant difference between the group. The S-lens and MQS3 score were only evaluated at the 6 months post-treatment. There was a significant decrease in both groups compared to the baseline, but there was no significant difference between the groups. In this study, both procedures effectively reduce radicular pain at 3 months and 6 months compared to the pre-treatment, and significant improvement in CNY, NRS11, SLANS, and NDI scores. SLANS neuropathic pain score at 6 months was significantly reduced in both groups compared to the baseline, but there was no difference between these two groups. And also there was no difference between the two groups regarding the decrease in drug consumption at 6 months post-treatment as calculated by the MQS3 score. In this study, spread to the anterior epidural space was observed in the 76.7% in the fluoroscopic group. A paramedian approach may prevent the catastrophic consequences of the midline ligamentum flavum defect, and the caudal epidural space should be administered at C7 T1 level, and if necessary uppermost C6 C7 level to reduce neurological complications. This ultrasound guided prevents vascular complication and allows direct visualization of the soft tissues and blood vessels, and non-particulate steroids are crucial to prevent vascular occlusions. Ultrasound guided selective nerve root pulse radiofrequency was performed for 4 minutes per level, which is longer procedure time than paramedian fluoroscopic guided procedure. This pulse radiofrequency treatment causes neuromodulations via micromolecular changes. This neuromodulatory effect is transmitted to the dorsal root ganglion and higher neuronal structures. Pulse radiofrequency reduces microglial activations, cytokines, and mediators that are involved in the pathogenesis of the chronic neuropathic pain. So the conclusion of this study is that both ultrasound guided and paramedian fluoroscopic guided epidural injections techniques are used for managing radicular pain. The choice of techniques be based on patient's conditions, preference, and availability of the resources. High cost of radiofrequency generator and cannula used in ultrasound guided selective nerve root pulse radiofrequency should be considered. The strength of the study focused clearly on the objective. Randomization was done, no significant complications have been noted, and outcome was clinically relevant. In the limitation of the study, there was no control group taken. Follow-up period is limited for the 6 months only, hence long-term effectiveness can't be evaluated. Not a cost-effective study, and single-center study. In the future direction, further studies needed to compare the long-term outcomes and effectiveness of the two techniques. Thank you.
Thank you, Dr. Ashish, for such a nice presentation. I think Jeshnu sir have joined. Welcome, sir. Sir, please share your comment on this research article. Dr. Ashish has
First of all, Ramveer, thank you for inviting me. It's always been privileged to join journal clubs like this. And congratulations to your society that you're conducting it regularly. Congratulations to Ashish also that he has presented very well. Few questions I would like to ask to Ashish, like with respect to this journal, authors have used Lance pain scale, right? Yes, self-assessment pain scale. So can you give a slight differentiation between what is Lance and S-Lance?
Sir, in this Lance questionnaire, this sensory testing was done by the examiner, but this S-Lance panel score on this 7 points scoring system predominantly is an interview kind of thing, and patient itself need to fill this S-Lance panel score questionnaire. And there's no sensory testing and this allodynia testing, altered pinprick threshold system, which was included in Lance, is not now including this S-Lance scoring system, sir.
So in that way, Lance would be better than S-Lance, right?
Sir, yeah, if sensory testing is, yes, sir.
Yeah, so in that way, for critical analysis, the points which you have highlighted, then at that point, you can add that it is better to use Lance. In fact, what I would say, when you're doing a scientific research, that it is okay if you are having a clinical practice that you are using unidimensional pain scales. But if you are in a research setup, then it is better to go for multidimensional pain scales like McGill pain questionnaire, right? So it would have been better, so that assessment would have been better for this thing.
Okay.
And Moreover, what I couldn't understand from this journal is that the follow-up cycles were for 3 months and 6 months, right?
Yes, sir.
But authors haven't followed up patient for short duration, like for 2 weeks or 4 weeks.
Yes.
Because whenever you're treating a patient in a real clinical setup, uh, you patient are expecting the results as early as possible. So based on the data which has been published from this article, it is not possible to derive the short-term outcomes of this epidural steroid versus pulse radiofrequency. Because the pulse radiofrequency onset of action, it takes at least around 4 weeks.
Yes.
Contrary to epidural steroid injection, which takes onset of action is within few days. So we need to consider that point also when we are treating the patient.
Yes, sir.
Right. So can you tell me why the transforaminal won't be useful in this cervical epidural?
Sir, I understand majorly because of this more vascular event adverse effects is associated with this transformal approach than this paramedian, and also this anterior epidural space is the space where this mainly this nerve compression is seen, so which is can be more better paramedian approach. We can access to this post that space than this transforaminal, maybe because of that these two reasons. Sir.
Transforaminal, you can reach anterior epidural space more easily than posterior paramedian approach, right?
Yes, but so vascular events.
Yeah. So most important thing is you're about vertebral artery. By any chance you puncture vertebral artery, that leads to catastrophe.
Yes,
So
sir.
never ever go for transforaminal.
Right, sir.
Okay. Not even ultrasound guidance, not even CM guidance.
Right, sir.
Then another point which I would like to ask about the duration of action for this non-particulate steroids like dexamethasone.
This, sir, maximum duration? Not sure, sir. Like, what?
See, various research will tell you about various duration of action, but it's few weeks only.
Yes, sir.
Okay, but still you are getting long-term benefit because the chemical reaction or what inflammatory reaction going on there subsides within few weeks, initial few weeks. Okay,
Okay, sir.
which which is not true with the pulse radio frequency. In fact, in pulse radio frequency, you are not handling with the inflammatory reaction per se, but you are going for neuromodulation there by affecting the microglial cells.
Yes, sir.
Okay. So that is how the PRF and this epidural steroid injection differs in mechanism of action.
Yes, sir.
Okay, that is all from my side that I wanted to ask few questions. If you have, another important point which I need to highlight for particularly to this article is about the age of the patient. Okay, so I think they have included from 25 to 75, right?
Yes, sir.
So for
18 to 75, sir.
yeah. So for
18.
epidural steroid injection has more beneficial effect on annular tear or PIVD. But as age progresses, the causes of radicular pain are more of the degenerative conditions than the disc herniation or annular tear. So in that case, the chances of failure of this steroid injection or PRF would be more. So you need to identify the cause behind this thing, cause behind this radicular pain, and then need to treat the patient rather than just blankly identifying that it is radicular pain and for the intervention. So most important thing which might have missed here is that we haven't discussed about the cause of radicular pain.
Yes, sir.
So common causes for like a common thing which are the effect PRF and steroid injection will be effective more for this PIVD and annular tear kind of thing, where your nerve roots are getting irritated. But in degenerative conditions like facet arthropathy or osteophytes of the facet joint or ligamentum flavum hypertrophy, your PRF and steroid injection might be effective, but only for shorter duration.
Yes, sir.
Yeah. Yeah, thank you, Ashish. That's what I
Thank you,
have
sir. Thanks a lot,
asked.
sir.
Jeshnu sir, share your
Yeah,
experience also. There's a question in chat box. What do you prefer among us two in cervical radiculopathy in your practice, sir?
what do I prefer in cervical epidural or PRF in my practice?
Cervical radiculopathy management in your practice.
I prefer cervical epidural injection. Okay. So there are three reasons behind it. See, first thing is I'm practicing in a private setup. Okay. So cost effectiveness is the first important thing. Where like patient, the first question that patient will start asking you once you explain about the disease and treatment is cost of the treatment. So important thing is about cost effectiveness. Second thing is, mm, though there are a lot of research articles which are in favor of pulse radio frequency, but in general, in clinical practice, it has been seen that pulse radio frequency itself do not have very good outcome for short duration as well as for longer duration. Whereas the steroid injections have been used since ages and have been found effective. So I prefer steroid injections. If steroid injection fails, then I go for pulse radio frequency.
Yes. So do you prefer giving steroid cocktail after the PRF?
Yeah, I would prefer to use, because as I told you, the PRF onset of action takes around 4 weeks. You cannot ask the patient once you are already putting needle inside the patient, and you cannot ask the patient to wait for a few weeks to have onset of action. So it is always better to give non-particulate steroid where the risk is minimalized, even if you are close to the vascular structure. Then inject a little bit of dexamethasone 4 to 8 mg near the nerve root. That will give some beneficial effect till the time your PRF action sets in.
Yes, sir. Thank you, sir. Sir, few question I have. Sir, what complication you have encountered while you are performing a epidural or PRF? What are the most common complications?
Frankly speaking, I have done only few cases of PRF very cautiously. So till now, I haven't encountered any as such complication for PRF as well as for steroid injection. Obviously, for steroid injection, when you inject contrast, sometimes there might be vascular spread. In that case, you need to reposition the needle, or sometimes even you have to abandon the procedure. Even if there is a vascular spread, even after the positioning the needle. But for PRF, as such, I haven't encountered any. For both the procedures, I haven't encountered any complication till now.
Sir, which one is better in your practice, PRF or cervical epidural?
I prefer I prefer cervical epidural.
Yes, sir. Yes, sir.
Because again, see, it's not only about the outcome. When when you're treating a patient, you need to see all. You need to treat the patient in a holistic manner.
Mhm.
So considering multiple factors, I prefer steroid injection. If steroid injection fails, then can go for PRF.
Yes, sir. Yes, sir. Sir, if there is a symptoms, means the radicular symptom recurs, after how much time you should do again procedure or you don't do the procedure? So what is that? What is your approach to the recurrent symptoms?
Okay, so you're asking that if there is recurrence of symptoms,
Yes,
after
sir.
how many days I should go for repeat procedure or another procedure?
Yes, sir.
As I said, I usually go for cervical epidural as my first step.
Yes.
If there is recurrence, at least after 4 weeks, I go for repeat cervical epidural.
Yes.
If again there is recurrence, then I go for pulse radiofrequency.
Yes.
That is routine way. There are few cases where in first step also I have done PRF, and unfortunately I haven't got very good result in all the cases. Like I have success rate around only 60% for PRF. So I stopped doing it as a first step procedure. Go for steroid, and if steroid doesn't work, then go for second steroid. If that doesn't work, then I go for PRF.
Yes, sir. So PRF can be repeated also, sir.
Yeah, PRF can be repeated anytime.
Yes, sir.
I think some more questions are there in chat box.
Sir, yes, sir.
There are some questions. Am I audible?
Yes, sir. Yes,
Yes.
sir. Please ask.
There are some questions. So, Dr. Jeshnu, what is your experience? What do you do in the post-procedure guidelines to the patient? Do you prefer using the soft cervical collar or any cervical orthosis to the patient to avoid painful movements? Anything as any rehabilitation plan do you prefer in your patients in cervical epidural after cervical epidural?
No. I don't give any orthosis. I only advise soft cervical collar if patient is traveling, where there are chances of some jerky movement. Then I only prescribe for only those jerky, only those traveling time to avoid jerky movements to neck. I advise them cervical collar. As such, there I don't advise typical rehabilitation program for at least about 3 to 4 weeks. That is what time is required for the healing, right? So till that healing process goes on, I won't advise any physiotherapy or any strengthening exercise or nothing. Only after 3 to 4 weeks, when patient have very good relief from the pain and radicular symptoms, then I ask the patient to go to physiotherapist. I personally don't do it in myself. That is job of a physiatrist or physiotherapist. I don't do it. I just refer them to physiotherapist.
Sir, one more question. What is the role of oral steroid in cervical radiculopathy? Will you prefer cervical epidural or oral steroid?
Cervical epidural, obviously, for reasons like you're bang on to the close to the cervical nerve roots. You're avoiding systemic side effects of the steroids, and as such, even in routine clinical practice, it is that we have seen it has been rampantly used oral steroids for cervical or lumbar radiculopathy both, but effectiveness of those oral steroid for radicular pain is not much. So it is always better to deposit your steroid close to the nerve root rather than exposing all your body to the side effects of steroid.
Sir, cervical epidural can be done in acute cases also?
Yes, can be done. But I only wait for at least 3 to 4 weeks to let the disease itself have some healing. Till that time, I just only I only prescribe NSAIDs and anti-neuropathic drugs, and let the body try to heal its own disease. If not, then I will go for intervention. But there is as such no contraindication. If patient is in severe pain and your NSAIDs and anti-neuropathic drugs are not working, you can go for epidural.
Sir, what are the precautions should be taken? You can tell to the audience before the cervical epidural.
Post procedure or like what?
Pre-procedure.
Pre-procedure precaution. Same things. Avoid lifting heavy weight on the head. avoid a lot of bending or a lot of forward bending, lot of extension. Avoid jerky movements. Like rest of like other basic routine activities can be done. Avoid going to gyms or jogging where you can have stress on your discs. Uh, all those basic things, nothing much.
Just before the procedure, if there is any precaution should be kept in mind before doing the procedure.
Uh, uh, just before the procedure, always go for basic blood investigations like complete blood count and coagulation profile. If there is impairment of coagulation profile, never touch the patient.
Yes, sir. Thank you so much, sir, for your kind words.
Pleasure
Now
is
we
all my friend. Thank you so much.
Thank you so much, sir. Thank you so much. Now we proceed to the second general club. Dr. Shalu, please start sharing your screen.
So it's visible, right? See us visible, right, sir?
Yes, yes, you can start.
Okay. Good evening. Welcome to today's Journal Club presentation. Myself, Dr. Shalu, Senior Resident at IMS Mangalgiri. So the title of today's research article is Intraarticular Injection of Bone Marrow Aspirate Concentrate or Adipose-derived stem cells for knee osteoarthritis, a prospective comparator clinical trial. So the article is published by Pinto in the Journal of Orthopedic Surgery and Research in the year 2023. About the journal, it has got an impact factor of 2.8 and 5-year impact factor of 3. So coming to the introduction, in osteoarthritis, breakdown of joint cartilage and underlying bone result in degenerative joint disease. So conventional conservative treatments showed limited clinical benefits without preventing the progression of OA or providing long-term improvements in functional joint. With the recent increase in interest in regenerative medicine, patients often undergo orthobiologic therapy. So what are mesenchymal stem cells? So they are multipotent cells with self-renewal capacity. The sources include autologous bone marrow cells, adipose-derived stromal cells, and umbilical cord-derived mesenchymal stem cells. So it has got the differentiation ability to form chondrocytes, adipocytes, and osteocytes. So it differentiates and help regenerate connective tissue capable of home into diseased tissue such as bone, cartilage, tendon, ligament, and fat. So mechanism of action of stem cells is by exerting anti-inflammatory, angiogenic, trophic, and immunomodulatory effects. So objective of the study is to find out whether autologous mesenchymal stem cell injection provide clinical and functional improvements in knee OA, and also to find out whether the results differ between the two, that is autologous bone marrow cells and adipose-derived stromal cells. So methods, prospective comparative clinical trial done on patients diagnosed knee osteoarthritis. A total of 102 subjects were taken as sample, and patients were allocated into either of the treatment groups according to their week of treatment. That is, 51 subjects were given bone marrow cells and 51 subjects were given adipose-derived stromal cells. So these are the inclusion criteria of the study. It's patients with clinical findings of knee OA with degenerative joint disease or knee radiographs. The exclusion criteria were age more than 75 years and KL grade of 0 and 1. BMI was less than 18 or more than 35. Patients with severe varus or valgus deformity and concomitant involvement of ligaments or menisci, infectious or inflammatory joint disease, and those patients who receive both knee arthroscopy and bone marrow aspirate or adipose-derived stromal cells at the same time. So coming to the methodology, we'll go to the preparation of adipose-derived stromal cells. So the procedure was performed by 2 trained surgeons. Step 1 is preparation of the patient. That is, patient was placed in supine position. Abdomen was prepared with betadine, and 5 ml of 2% lidocaine was injected at the site of skin incision. Here, the harvesting area is abdominal subcutaneous adipose tissue. Step 2 is injection of anesthetic solution. So, small incision was made over the harvesting area of the abdomen. Then, here the tulip soft harvest gold system was used for the procedure, which is shown by figure 1. Next, a harvesting cannula connected to a 60 ml syringe containing a solution of 240 ml of sodium chloride, 20 ml of 2% lidocaine, and 0.5 ml of 1 mg per ml epinephrine was injected into the subcutaneous layer. Third step is lipoaspiration. This, after 5 minutes of giving anesthetic solution, a harvesting cannula connected to a self-blocking 20 ml syringe is introduced into the subcutaneous fat and lipoaspiration is done, shown in the figure 3. And after the lipoaspiration, 10 ml of tranexamic acid is injected, then compressive dressing is applied. And step 4 is filtration of the aspirate. This dry lipoaspirate was collected in a 20 ml syringe. After expelling the fluid by manual pressure, this fat-containing syringe was passed sequentially 30 times through a 2.4 ml, 1.4 ml, and 1.2 ml layer-to-layer transfer device connected to a 20 ml syringe, which is shown in the figure. Then next one is pre-emulsified the lipoaspirate is collected in a sterile nano-transfer device and then passed through 0.6 to 0.4 ml mesh stream into an empty 10 ml syringe. Finally, aspirate of 10 ml is ready for injection into the knee joint intraarticular. After the injection, post-procedure, at discharge, patients are instructed to wear elastic dressing for a week to prevent hematoma on the abdomen. And full weight bearing on treated knee is allowed after 1 week. Isometric quadricep strengthening are started after 1 week. Next is the procedure for bone marrow cells. So this is also performed by 2 trained surgeons. Step 1 is preparation of the patient. Patient placed in supine under sedation and prepared with betadine. Here the harvesting area is proximal tibial metaphysis. So marrow solution bone marrow aspiration system is used for the procedure. Step 2, a small skin incision was made and a preparing cortex 13-gauge needle was introduced past the cortex into medullary space. Then a sharp stylet was removed and a blunt stylet is inserted. The needle was advanced to the desired depth with rotating or guide grip skin level. Next step, this blunt stylet is removed and aspiration cannula is connected to a 10 ml syringe. And 10 ml of bone marrow cells was aspirated, holding a guide grip and rotating the handle 360-degree counterclockwise to allow fenestrated stylet to be raised to a new level of undisturbed marrow. Finally, 10 ml of harvest is ready for injection to the knee joint intraarticular. And after the injection, full weight bearing on the treated knee is allowed after 1 week, and isometric quadriceps exercise is started after 1 week. So the outcome tools used in the study are score scoring, that is knee injury and osteoarthritis outcome score. It assesses 42 items, and items assessed are pain, symptoms, ADL, sports and recreation function, and quality of life. Next one is Oxford knee score. It has got 12 items to assess pain and function. Then the third one is VAS scoring. All these assessment is done with the 1 week before the procedure and 1 and 6 months after the procedure. Coming to the results. So this table shows the baseline demographic details of the patients in the both groups. So number of patients in the both groups are 51, with 29 patients in bone marrow group and 27 adipose-derived stromal cells group. The mean age was 57.64 in the first group and 61.94 in the second group. So this table shows the core scoring in the both groups. So if we see the core symptom score, we can see in bone marrow group, pre-treatment, the mean score was 55.23 and it has improved to 84.13 at 6 months interval. Similar changes we can see in the adipose-derived stromal cells group. Improvement from 52.73 mean value to 85.91 at 6 months follow-up. Similarly, we can see same increase at the 6 months in the both group. And there is no difference in the core score when we compare the both groups. This third table shows similarly VAS scoring and Oxford knee score of both groups. Here we can see in the both groups, VAS score has improved, that is decreased from 6.17 to 2 and 6.1 to 2 in the other group. Similarly, OK score also improved in the both groups. Similarly, so when we compare the both groups, the difference is not significant. And this table shows all the scoring, that is scores, VAS score and OK score, according to the grade of the osteoarthritis, according to Kale grading. From this table, we can observe that the improvement in all these scorings is more in patients with a Kale grade of 2 than in patients Kale grade 3 and 4. So coming to the discussion part, according to the study, adipose-derived stromal cells and bone marrow cells Improved clinical and functional outcome in knee osteoarthritis patients at 6 months follow with similar efficacies. Patients with mild OA, that is with KL grade 2, have better clinical and functional result than patients with KL grade 3 and 4. And both bone marrow harvesting and lipoaspiration are minimally invasive procedure, last about 30 minutes and carried out as this procedure. The pre and post-operative MRI imaging can be done to evaluate the cartilage status. After the age of 75, proliferative capacity of mesenchymal cells is reduced. Age could represent a limiting factor for autologous harvest. And total number of mesenchymal stem cells collected from both methods have not been estimated. It forms only a small percentage. Thus, the clinical effect are most likely through a combination of angiogenic, anti-inflammatory, immunomodulatory, growth factor effect. Coming to the conclusion of the study, study has concluded that both BMAC and adipose-derived stromal cell intraarticular injections are effective in improving pain and functional outcome at 6 months follow-up in patients with OAE. And there is no statistically significant differences between the both groups in terms of clinical and functional outcome. Coming to critical effects, so these are the strength of the study. Results are valid and reliable. The recruitment process was rigorous and data was collected in a scientific manner. And validated outcome scores are used, and results obtained are clinically relevant, and no significant complications have been reported. Limitations of the study are randomization was not done for the treatment. Comparison with other therapies such as placebo or other injections like hyaluronic acid, PRP, or corticosteroid was not done. And only patient-reported outcome measures were considered in the study. So short-term follow-up was done. And future directions. Future studies of mesenchymal stromal cells in intraarticular injections are necessary to assess the MRI features and the efficacy of mesenchymal stem cells on cartilage status. Further RCTs with long follow-up should investigate which autologous orthobiologic source is most effective in OA. And also further studies to evaluate the efficacy and safety of varying dose of stem cells is required. Thank you.
Thank you, Dr. Shalu, for nice presentation.
Yes,
now I invite Dr. Prableen ma'am to comment
Yes.
on this research topic, ma'am. Please, ma'am.
Good evening, sir. Good evening, Dr. Ranveer. So, two things in this article I found. One was that the follow-up was taken at 1 month and then 6 months, which is a long gap, which I felt. Ideally, when you are studying such a patient doing orthobiologics, that to advanced orthobiologics like bone marrow and adipose stem cell, it should be also done intermittently at 3 months. What I am seeing in my practice it at 1 month, if it is a grade 2, the patient would definitely give you a good feedback. But if it is grade 3, at 2 months, certain movements of the patients, they would have that stiffness, but the pain would have started reducing. But it is at the end of 3 months that you get a positive, satisfactory response from the patient. So that was one thing that was missing. It should ideally be also taken at 3 months. That is a benchmark when the patient is able to give you a good feedback, to be honest. Okay. And the second thing I felt was that there were scores of Kellgren, Lawrence, grade 2, 3, and 4 in that. Of course, they are comparing that. Of course, grade 2 would be giving us better scores, right? So a comparison between putting grade 2 with 3 and 4 is not suitable. Ideally, for grade 2, you can just stick to PRP and GFCs, is what I will say as per my practice of regenerative medicine of 5 years, that you can just reserve such an advanced orthobiologic for a greater grade like 3 or advanced grade 4 in patients who do not wish to go for TKR.
Okay.
Ma'am. Nice, ma'am. Ma'am, how is this BMAC and ADSC is feasible in India? How much cost it is?
Sorry, sir. How
The
much
feasibility
is?
of cost and how much it
Feasibility, right.
feasibility.
So, of course, the cost is high because the kit is also expensive. But I would say that for bone marrow, it is still much feasible given like I am in a tier 2 city, Jaipur. But still, it is easy to if you counsel the patient well, you would be able to, it is very much feasible to do bone marrow aspirate injections since PRP is something that people are aware of. So if you counsel the patient, that it is your own body which is going to regenerate. The patients understand that, and generally these are those patients. Of course, you would have done PRP on few patients and they would have gotten treated. Through them, there are a set of patients that arrive at your clinic, and when you see, I'll give you an example, like if a female in her 40s is coming to you and you see a early grade 3, so of course you have to do something for her so that you can take her close to 60 age group, when if she wants willingly, the surgeon would give her do a TKR for, right? So right now, whichever patients I have done bone marrow for is in the age group of 40 to 46, because these are generally females or young males, I would say, mostly females, and they are all having grade 3. I have not done bone marrow aspirate concentrate injection for a grade 2, because for grade 2, PRP is serving very good results. GFC, if you use 2 tubes at the same time of GFC, it is serving very good results for 1 knee, I'm saying. But yeah, for grade 3 and 4, if you are seeing, definitely BMAC is feasible. You just have to counsel the patient that your own body is actually going to regenerate, and I'm going to, harvest it from this particular site. One point in the article, the proximal tibia is the site of harvestation in this, which I feel, so in our body, all the different bones have a level of bone marrow in it. So like mandible is the richest source, but you cannot possibly harvest it from there, right? So the second best is PSIS, posterior superior iliac span, and then comes the ASIS, and then comes the proximal tibia. So one thing, maybe the surgeon felt that it is easier because it is superficial, and he chose proximal tibia. But then in my practice, I prefer posterior superior iliac spine. And I would say that that is easier, and you get a more concentrated bone marrow aspirate compared to the proximal tibia. So you have to counsel the patient that, I am going to aspirate it from here. You would be given a local anesthetic, and this would not cause pain at a later date. All these things you have to counsel. It is a part of your blood that we are taking from, it is marrow, it has stem cells, and it would regenerate, and this we are giving in your knee, and your knee in itself, your body would be healing it. So this is something which resonates with the patient that I have seen, and they easily get converted if they actually want to get better.
Hello, Dr. Prableen.
Hello, sir.
I want to ask you that in this article, the author made this BMAC by just aspirating it and just directly injecting into the knee. I think usually we do this centrifugation for this. No? I
Yes.
think so.
So, sir, I'll tell you what they have done in a very crude method.
Yes, the crude
right?
method.
They've just taken out and then they have given. It is a very crude method. But having said that, I would say if you are having some marrow cells in it and you are, depositing it somewhere, it will definitely start working. First thing. But yes, if you want to ask me, so then properly, if you ask the steps, yes, you have to harvest it from either the iliac crest. I am comfortable with posterior superior iliac spine, because if you make the patient lie down prone, it is almost a 90 degree with only 10 degree tilt that you can just, using the C-arm guidance, you can just enter.
Okay.
And you can easily aspirate anywhere between 40 to 60. Sometimes you might get stuck at 30 ml or so, which happened to me initially. But what I found is if you preload the patient an hour before the harvesting with one, that 500 cc of RL, you would easily aspirate a 60 cc of BMAC. And once you have done that, so there are prepared kits. So Tricell has a very good kit. And then you have Recus who are into PRP, but they are also making good kits of BMAC. So in that, you can only fill, obviously if you're going to do it, for someone you're going to do BMAC is generally for both the knees. Because as I said, I'm doing it in 40 plus and they have grade 3. It is generally both the knees. Maybe one would be late grade 3 and one would be early grade 3. So you need 2 kits, and if you are aspirating 60 ml, you can easily divide, 30-30 in each.
Both the kits.
There's a filter in the kit, which actually is of 30 to 60 microns. So it will actually take away the extra remnant particles of maybe the cortex of the bone. That all is removed in it. Sometimes now bone marrow, blood also clots very quickly. So you have to shake it. It clots faster than the venous blood. So sometimes those clot also would get entrapped in that filter. And in that tube, then you centrifuge it. So each kit has its own, said rules. The one that I am using, it is 25 minutes, 20 minutes for 4,000 RPM, the kit that I use. And then you get the supernatant. The supernatant that you get, if you divide it into 3 parts, the lower 1/3 is where the bulk that we want, the marrow cells, the mesenchymal stem cells, are in surplus. So that is what you would, and of course, when you are taking 2, 30 ml, that is sufficient. It is usually, 6 to 7 ml that you get. And for both knees, 7 ml, like one knee 7 ml and the other knee, it serves the purpose.
In this, if we compare BMAC with PRP, in BMAC, already we are getting after 30 ml of this bone marrow aspirate, we are getting around 6 to 7 ml. And in that also, the proportion of mesenchymal stem cells, as per the article also and as per the other research articles, it is around 1 in 1,000 or 10,000 cells. So it is very, very less. Also, it has been proven in studies that these stem cells, they get 90% of these stem cells, they die or they get lysed within 24 hours of the injection procedure. So how do you propose what is exactly the mechanism of action of these stem cells other than different than the PRP or the growth GFC?
So, sir, I would say that firstly in BMAC, the count that comes, if you search for the literature, you can reach up to 10 billion with BMAC, which is much larger than PRP, number 1. Number 2, I would not agree with the lysing part, but yes, we always say that use a temperature regulated centrifuge. So I am using a temperature regulated centrifuge for PRP as well as BMAC. It is the same centrifuge. Even for PRP, it should be a temperature regulated, of course, because otherwise we even if we check, we are getting on the counts on the automated cytometry that these many cells we are giving, but actually we are not aware how many of them were active. Right. So in any case, a temperature regulated centrifuge is must, number 1. And having said that, I would say that BMAC, as I said, PRP, why I shifted to BMAC was because for up to grade 2, I was getting very good results with alone PRP. But for grade 3 patients, they were not that happy. Even, of course, you have to add physiotherapy, you have to add, in the article, it was only mentioned about isometric quadriceps. But I would say that VMO is something that is missed. Always, vastus medialis obliquus has to be targeted. Even if we are adding that, grade 3 patients, I felt, were not as happy. But BMAC is something which actually has potentiated stem cells, and that is giving, and I would not say that it lyses. If you have actually prepared it in a closed system, you have prepared, you are maintaining the sterility, you have also regulated the temperature, definitely it would. Another thing which I have read in articles and people in conferences where I have attended, they have told that you can ask the patient to ice every 2 to 3 hours if you want to prolong the that icing.
Reduce the blood flow.
Yeah, you can prolong the marrow cells that you have, like in the case of PRP, you prolong and they don't lyse quickly. But practically, I only advise it if some patient faces pain and swelling, which increases after the procedure, because it is a reactionary synovitis. In that case, I would say that yes, you keep icing. Otherwise, I don't prefer that. And so practically, clinically, if I tell you, the results are good. I would not say that it gets lysed. It is way better than PRP.
Okay. Thank you. Thank you.
Ma'am,
Welcome.
do you prescribe NSAIDs after the procedure?
No, sir. Because NSAIDs and platelets, if we talk about, both act on the sodium channel. So you would not use that. But frankly speaking, to be honest, sir, they don't require anything. Okay. Most of the patients, they don't require anything. Some patients, as I said, they have reactionary synovitis, in which case I would say that you take PCM, because paracetamol is going to work only on the COX-3 pathway, which is fine. And in case if the pain is more, you can ask them to use tapentadol, which is also again safe, and ask them to ice every 2 to 3 hours and reassure them that for 48 hours you would feel this stiffness. Just keep your legs straight, do all this. On the third day, it would reduce. By the fourth day, it would have gone. I can see Jeshnu sir has raised his hand. I would want to address to him. Yes, sir.
Sir, please unmute yourself.
I wanted to ask, like, at what temperature do you keep the centrifuge for different things, both for PRP or
It is
BMAC
fixed.
or...
Sir, it is fixed at 22 actually, the machine setting.
Okay.
Ma'am, how much does it cost for the instrument for ADSC or your BMAC?
So, sir, ADSC, now they have prepared using some kit I'm not aware of, but Meditech has one kit, and that whole system for adipose is 65,000. So, Dr. Sharmila Tulpule ma'am is there, orthopedician. She has the patent and rights to it. Joint Tech Labs, actually, Joint Tech Labs under that name. That is 65,000, that kit. But it is very sterile. So even here, the system of, I saw that it was a little bit of it was just extracted and then they have made. So usually for 2 knees, you require at least 100 to 120 ml of the fat suction. So usually this Joint Tech Lab has a 65,000 kit in which they have a microprocessor, micronizing device, which has multiple ports and they have connectors to different segments. So firstly, the advantage is that it is a closed system, so it stays sterile. And second thing is that you wash. Firstly, you would divide the the abdomen paraumbilical into 4 quadrants, and for 2 knees you can just infiltrate 2 quadrants. Also there is a difference between what we do and what is mentioned here. So it is 500 ml of NS with 30 ml of Loxicard and 1 ml of adrenaline combination that is used, and around 200 ml is infiltrated while breaking septas on one side. And out of which, after that, you have to leave it for 20 minutes. That was also not mentioned here. Why to leave it for 20 minutes? Because the adrenaline has to act and vasoconstriction has to be done. So here what they did, they used tranexamic acid to control the blood vasoconstriction. So you have to leave it for 20 minutes so that vasoconstriction can happen. Post-procedure, the patient would not complain of ecchymosis then. Otherwise, the patient would come in a couple of days with ecchymosis. So that is one aspect that has to be taken care. And this Joint Tech entire system kit, you collect the aspirate, lipoaspirate, you infiltrate in that, you wash it with the RL, and then it is as per the rules. You actually give it 1 centrifuge, then you again wash it, you give it another spin. So after 2 spins and after removing all the Wenger lactate solution, the final product that you get, you actually mix it with a little bit of PRP. Meanwhile, you have to take blood of the patient and you have to mix it with PRP so that these mesenchymal stem cells are activated. Also, second thing, it is difficult to actually, give the ADSCs in the knee. You have to make it a little liquidy, and PRP serves that purpose. Yes, sir. Sir, Jeshnu sir, I can see you.
No, it was a comment on this. So,
not so.
SNRP is not referred.
Thank you, ma'am. Thank you.
it was
Jeshnu
a
sir,
really very illustrative explanation of both the procedures. Thank you, ma'am. It was a
Thank
very great explanation for both the procedures. So,
Thank
any
you,
other
sir.
questions from any other audience?
I
So
want to ask
Jeshnu
one
sir
question.
has his hand raised. I wanted to know.
No, that was long back.
Okay,
You
okay.
answered. Thank you.
Sir, one thing I would want to mention here regarding the previous article, I read the questions at that time. So, rightly said, sir prefers cervical epidural, but I would want to share my thing. If the patient is lean, and because if the patient is lean, it is very easy to see all these structures on ultrasound. So, because there are many questions about SNRB, I'm answering this. I prefer a selective nerve root block in those patients. It is when fatty patients are there, a lot of fat is there, and because the nerve roots also are, hypoechoic. It's only the cervical nerve roots that look hypoechoic compared to everywhere else where nerves are usually, the fascicles are very hyperechoic. So in those cases, in fatty patients, I prefer going for cervical epidural. But having said that, I would say it also depends on your ease. I am more comfortable giving selected nerve root blocks because I am sure of the blood vessel. I can see the vascularity on ultrasound. So that is something one can actually personally choose. And in obese patients, since the visuality on the ultrasound image is not that clear, which is when I prefer a cervical epidural. For those who have asked SNRB, I wanted to answer that.
Definitely. I also agree with the same. I also prefer ultrasound guided cervicals SNRB in lean and thin patients. And in the stubby patients and the thick patients, I prefer fluoroscopy guided cervical epidural. But there is a chances of false LOR in fatty patients also there. So,
Okay.
Dr. Jeshnu, would you please comment upon false LOR during the fluoroscopy guided cervical epidural procedures?
Sure, sir. It is very common to get false LOR. It's
But we
not
can,
the
sir, always
incidental
see
case.
that contrast spread. Na?
Yes, but good thing is that you inject the contrast and you see it in both oblique or lateral and AP view.
So
But
which,
after
sir, you
but after
prefer that
injecting the
contralateral oblique?
Contralateral oblique, I take.
Okay, same.
but actually after injecting contrast, then the visualization is gets very poor. So what do you do after
Yes,
that?
sir, it happens. Like if your needle is not into the epidural, just behind the epidural space, and it comes out of the space,
Yes.
needle tip visualization get blurs. So what I do in such cases, it's very common and it happens with everybody, sir. So what I do, I just inject some distilled water or normal saline just to wash out that contrast.
Okay.
Provided it is not in the epidural space. If it is in the epidural space, your job is done.
Yes.
So
And
once that contrast get washed out, you can very well see the needle tip. Then you can go on inserting the needle.
sir, also, like I'm just taking this out because you mentioned that you don't ask for rehabilitation for 4 weeks with the patient. Those you have done cervical epidural. So there, I have a different opinion. Usually, those who are having cervical radiculopathy, generally they are also having with the neuro component, the myo component. They have trigger points on the trapezius, deltoid, even the brachioradialis. So what I give instructions, since I have an in-house physiotherapist, what I give her instructions is I call the patient, I give them a timeline of 7 to 10 days, so that they can assess of the relief, and then they come, and it is on these trigger point manual therapy releases that she starts working on, my physiotherapist. We
Yeah,
start in a bit early. But yeah, the strengthening part after 2 weeks. Strengthening
Yeah.
after 2 weeks, but release after, like, maybe some patients come at 70, but some need 10 days. So that
I
is why.
partially agree with you. What I do is I don't advise them physiotherapy. I just prescribe them muscle relaxant with NSAID and your anti-neuropathic drugs. So muscle relaxant most of the times do the job. Because why? Again, that is like my personal that there is differences in opinion in this. Not only
Correct.
on the personal level, but if you go on the research level also, there are differences of opinion. Certain researchers don't advise physiotherapy at all or rehabilitation at all. Certain there is another group which advises rehabilitation as early as possible. So what I do, if there is still ongoing myofascial pain after 3-4 weeks, then I advise them for physiotherapy. So it depends. There is no rule of thumb. It's all personal choices.
Crucial.
Definitely. So any other questions? Let me see.
Jeshnu sir,
I think. No, Dr. Rambir, please.
yes sir. Sir, is diabetes is a contraindication for cervical epidural?
No, not at all, provided the sugar is within normal limit.
Okay, okay. So sir, what are the options for if a patient have uncontrolled diabetes?
For uncontrolled diabetes, go for pharmacotherapy and for physiotherapy. Let the sugar get controlled well with the help of your physician, and then you can go for intervention. See, as you are injecting steroid and patient sugar levels are already raised with the steroid, they will again keep on raising. So we don't want that. So let the sugars be within normal limit, and then you can inject steroid.
There is a question from Dr. Aradhana Shukla to Dr. Prableen. Ma'am, do you think using mesenchymal stem cells in grade 4 osteoarthritis is worthwhile when the actual pain in that state is more of biomechanical in nature? The ligaments in the knee at that time are extremely lax or broken. Subchondral bone is also, and there is no resting pain. Can we expect regeneration to be of that extent to address all these biomechanical issues by regeneration?
No, so as I said, I do it for grade 3, early grade 3 and late grade 3, but not grade 4. Second thing, my preference, see, for BMAC also, as we studied in that article, there it is mentioned after 75, they have not included in the list. But there is a certain article on the net that you would search, you will find out, which is actually telling you that in this age, it is this much, and then at this age, so in 30s it is in a good state, 40s just similar to the 30s, in 50s age group it has already declined a bit, but still it is in a good state. Post 60, in the 60s age group, the BMAC, the marrow that you would get from the PSIS has also decreased. So I don't prefer BMAC 60 plus. And of course, in India, we have so much of osteoporosis, right? So you're going to harvest also. So that is not something that is advisable. And if a patient of grade 4 comes to me, my first counseling is for total knee replacement, even if it is, we are giving away our patient, but I suggest TKR because that is something the patient will be happy with. But yes, if the patient is not willing or there are conditions, health conditions that the patient cannot go in for a TKR, then you can go in for RFA of genicular nerves, that to the revised version, that like all 6 branches covered, not the conventional 3, which gives a little less of a. Jeshnu sir would be able to comment more on it. But in my personal experience, only targeting those 3 genicular nerves doesn't give that good result. So you can do RFA for such a patient, targeting the infrapatellar branch and nerve to vastus medialis, including that as well. But BMAC for grade 4, not advisable.
Not advisable. I think we can conclude the session. So, Dr. Rambir, please.
Sir, one question to Dr. Prableen. If you're doing BMAC, for how long do you expect the good outcome? Like,
So, sir, all the patients that I have done it for, there has been a trend that I have studied. So, if I only talk about OA knee, if it is early grade 3, so if the patient has in one knee it is early grade 3, definitely in other knee it is a little more, it's late grade 3. So what I have observed is at the end of 1 month, at and also I start off with early physio. Like generally the patients do not have pain. Sometimes it would happen that out of the two knees, in one knee they have a reactionary synovitis. So I just wait out that period. It is usually 2 days of peak pain, third day moderate, fourth day it has reduced. So from the fifth day itself, in such a case, I would say you start doing the physiotherapy. Now, at end of 1 month, the knee which has a lesser grade, the patient would always be in her or his mind comparing the two knees. They would give you a feedback कि this knee में तो मैम नहीं दर्द हो रहा, मुझे तो आराम लग रहा है, पर इसमें ना अभी भी है. So the knee which has a greater grade, that at 3 months the patient would stop complaining to you. Even at second month, they would give you a feedback that it has reduced from the first month. But abhi bhi when I'm starting to exercise, so we are feeling, a bit of pain and stiffness. And once the exercise and all is being done, then we feel good. So that complaint, sir, goes away by 3 months, end of 3 months. So even we had a patient who's an international kabaddi player. She had a focal chondral defect. She's only 30. She has a focal chondral defect, and it's been 3 months now. And at 3 months, she had no pain. At 2 months, she was complaining of stiffness. But when she came to us, she was not able to walk stairs also, because that the femoral condyle focal chondral defect was getting irritated whenever she was trying to climb stairs. So, sir, excellent results are there.
And what would be the duration of this effect? Obviously, it will depend on the rehab and everything, like how patient takes care of the knee.
Yes, so that I'm yet to comment, because as in this article they have said that they had only taken follow-up till 6 months. So even I don't have a follow-up of more than 6 months right now. But a single BMAC, like in PRP, my practice is I do 3 PRPs. And I do it 3 PRPs at a gap of 2 weeks each. But for BMAC, I'm seeing that I am getting good results with a single BMAC injection. So in that way, it becomes cost effective for the patient. Also, feasibility, Rambir sir had asked me. So I would say we can counsel the patient like this also. If someone wants to incorporate this into their practice, BMAC, you can counsel the patient like this, because in my practice, I had counseled the patients like this, that PRP, like 2 weeks, I would give you 3 sittings, and this is what is expected. And in BMAC, since it is potential, it is having potential mesenchymal stem cells, I would give 1 sitting. And I have the follow-up only till 6 months, sir, till now. But it's been good. Let's see.
Yeah.
So thank you, both the panelists, Dr. Prableen and Dr. Jeshnu, for a wonderful talk. Thank you, our speakers of these general clubs. So that was a very excellent discussion on part of both the speakers and the panelists. So I would like to conclude this meeting. So good night to all. Thank you. Thank you all.
Yeah.
Thank you
Thank
all.
you for inviting us, sir. Thank you for having us over.
It was a great for us, so that that both of you were with us, and you shared your expert opinion on both these topics. Thank you, ma'am, and thank you, sir.
Thank you, sir. Thank you, sir.
Thank you,
sir.
sir.
Thank you.
Thank you, sir. Thank you.